Hello and welcome to ECHOMAP, the practical, easy, and above all, useful ultrasound for general practitioners. Today's program is all about gynecology. I know this is a topic you particularly enjoy and ask me about regularly, so your wish is about to come true. If you like this channel, don't hesitate to give me a like, subscribe to the channel, a channel where we talk about real and authentic clinical cases from a general practice office. So of course, when you request topics, it depends on whether those cases are actually coming up in consultations at the moment. We're not responsible for what patients bring to us, obviously. Same thing on Facebook. Give it a like, subscribe to the Facebook page to stay updated on the release of new videos. And as I'm making this video, your introductory ultrasound training is still available for free. The link is in the description. Just click on it to join me in a training session to learn how to use your ultrasound device. And hopefully help you get started with ultrasound too, because it's an absolutely wonderful tool that provides tremendous benefits to our patients every day. So today we're going to talk about the case of a young 13-year-old girl who's been experiencing pain, let's say in the hypogastric area and left iliac fossa. Chronic pain, mainly before her period, which seems to have gotten a bit worse lately and is worrying her mother. And there you have it. And the mother would really like us to take a look. So on palpation, well, let's say the left iliac fossa is tender. So I thought, might as well do an ultrasound, since the machine is always on right next to the exam table. That's a good piece of advice I'm giving you. If you want to get better at ultrasound, well, you shouldn't hesitate to scan a lot and often. So the first thing to do when you arrive is to turn on your ultrasound machine. That way, when a clinical case comes up, you'll be more likely to quickly use the probe and it won't take much time. So, as usual, we're going to place the probe on the painful area. That's why it's important to do a clinical exam beforehand. You identify the most painful spot during the clinical exam. It's very easy, only takes a few seconds, and you place your probe exactly at that spot. And here's the first image we get. This is a real authentic clinical case, and this really is the first image I obtained. So we notice that there's something anechoic, most likely fluid, since there's a significant posterior enhancement. Then I'll stop there with the analysis, because my second good tip in this video is that you should always adjust your image before drawing any conclusions. In my opinion, you shouldn't rely on the presets. Presets are something that's set up in a general way. They're meant to save you time. In other words, when you use a preset, you'll never get a terrible image, but on the other hand, you'll also never get an excellent image for detailed analysis. And we know that with ultrasound, the analysis needs to be detailed because it's difficult, so adjust your image. So we're going to adjust our image. And here's what we're going to get on video, and we'll analyze it together. So the posterior enhancement is obviously less visible. On the other hand, we have a bit more detail in the area of the mass. So we notice that we do indeed have a mass that is anechoic with content that is generally heterogeneous. We'd say there are septations, hyperechoic lines within the mass. We notice that there's a wall that's clearly visible, still relatively thick, a bit irregular here, and a little irregular at the bottom in terms of thickness. Within the mass, an image that's rather, yes, let's say rather hypoechoic, with hyperechoic punctuations, and that already starts to give us a little idea. The location of the mass is just next to the iliac vessels, which are visible here. We're on the side of the bladder, so most likely a mass corresponding to an ovary that we actually saw briefly here on the side. So we have an ovarian mass that's rather cystic, heterogeneous, with hyperechoic septations, posterior enhancement, and a thick wall. We're going to measure this mass. Here, the mass measures almost 5 centimeters in diameter. That's important. Notice here, this is a bit important for what comes next, this slightly hyperechoic area in the wall. There you go. And also, take a good look here. You can see them very clearly, these lines. These hyperechoic lines and these small hyperechoic dots, which we'll see better in the video in a moment. Always remember the basic rule. Perform a Doppler on all masses, especially ovarian ones, because ovarian masses can be very misleading. There are significant risks involved. Now, in this case, it's a young patient, but if you discover masses in an older patient, there are obviously significant risks of tumor lesions. So, we're going to perform a TABIA. Here, this is a special type of power Doppler called SR flow, which increases the spectral resolution of the Doppler and therefore its quality. You can see that the iliac vessels, of course, will light up strongly, especially since the Doppler is set to high sensitivity. You'll notice there's still a bit of artifact, especially here. It looks like this image is sparkling a bit with color. That's normal. When you perform a Doppler, especially for tumor lesions, you absolutely have to push your Doppler to its limits. Not to get a perfect Doppler quality, because here you can see the Doppler is bleeding, but to make sure that within the mass there really isn't any circulation, not even minimal or very slow. So once again, notice these punctuations that you can see very clearly here and here, alternating between hyperechoic dots and hyperechoic lines. Here a hyperechoic line, here hyperechoic dots. So this is more or less what you get with the Doppler. So obviously there's a circulation that looks a bit peripheral, but in any case, there's no circulation within the mass. So most likely there are no signs of malignancy or any concerning signs in terms of vascularization. Of course, we're going to do a double grid scan. All masses or lesions identified on ultrasound should always be analyzed using multiple imaging planes. Note that the different imaging planes will give us information about the contents of the mass, because here, on a slightly more sagittal view, you can see that we've lined up the iliac vessels a bit more. Alright, here we notice some lines that are all going in the same direction, with some small hyperechoic spots as well. When we change direction, again, we see these lines and little spots. In some areas, the walls are a bit more echogenic. In any case, behind the mask, there's no shadow cone. So, as you've understood, this is a dermoid cyst, or mature teratoma, which means exactly the same thing. Here's a little illustration of a dermoid cyst. So, the criteria for diagnosing a dermoid cyst, the imaging criteria, and we'll talk about the concept of diagnosis afterwards, are as follows. The presence of hyperechoic lines or dots that will intertwine, right? Because depending on the imaging plane, you'll see either dots or lines or a mix of both on the overall image, which actually correspond to connective tissue, most often hair and hairs. Rokitansky nodules, which are actually hyperechoic lesions that are located at the wall, that will slightly thicken the wall, and which are actually accumulations of sebum, and they can also be accumulations of bone, or sometimes clumps of hair as well. So if we have something calcified, then obviously we might see posterior shadowing in dermoid cysts. That's quite common. Here, in the image, there wasn't any, as I mentioned to you. We can have lesions that are fluid-filled, with cysts within the central heterogeneous area. And then, of course, and this is very important, as we've emphasized, there is no Doppler flow. So here's a bit of a summary of this image. With these small lines that we notice at the level of the lesion, some areas that appear more anechoic and more fluid-filled, some punctate spots here, and a thickening here at the wall that is somewhat hyperechoic. One might wonder here if this isn't a slightly calcified area, like dental or bony tissue. You can actually find teeth in dermoid cysts. So here is the posterior acoustic enhancement, which shows us the cystic nature of the lesion. So regarding this lesion, in my opinion, it is a dermoid cyst. And I want to emphasize in my opinion, because it's very important to include in your imaging reports, at least this is my advice, this standard phrase, ultrasound does not provide a histological diagnosis, since, as far as we know, no biopsy has been performed on the lesion. So you can't be certain that it's a benign lesion, even if there's no blood flow within it. You can't be 100% sure that it's a dermoid cyst. There's always a risk of being wrong, you know? Imogen provides a set of arguments, but of course, the microscope is always right. And so the real and final diagnosis of this lesion will only be made after laparoscopy and pathological analysis. So that's it for today. I hope you enjoyed this clinical case, that you found it interesting, and that it was helpful to you. If that's the case, please don't hesitate to give a like, subscribe to the channel, and leave a nice comment, because honestly, it makes me really happy to read your messages. Same thing on Facebook. And your introductory ultrasound training is available for free. So if you want to get started too, just click the link and go for it. Ultrasound is amazing. It's fantastic. See you very soon on ECHOMAP.
Bye-bye.